Hello everyone. Today we are going to discuss about sources of health information. That means from where we are getting all this health information. Say for example, crude death rate is this much, crude birth rate is this much. So all this health related information from where we are getting, we will see today. And I am Dr. Anusha, Assistant Professor in the Department of Community Medicine. And this question is important for short notes as well as very short, and sometimes it can come as long also. Before going into sources of health information, first we should know some terms like raw data, what is raw data, what is information, and what is intelligence. And first we will see what is raw data. Raw data means these are discrete observations of attributes or events. That means just we are seeing numbers which are having no meaning. Say for example from Telangana. So total Telangana we are taking and we are seeing how many eligible couples are there in each district and how many children they are having, how many are the target couple. So like that data from all the districts in Telangana. So here we are just getting data like in district 1 this many eligible number, just a raw number will be there, so that is nothing but raw data. So before analysis and before processing we cannot interpret anything from that. Say for example from district A, so 500 eligible couple are there, district B 600 eligible couple are there, so like that we will get raw data numbers, and it has no inherent structure or meaning unless we are interpreting it or unless we are analyzing it. And this raw data is inadequate for planning because it is not giving any meaning unless we proceed it further. And this raw data has to be processed and has to be analyzed to get information. So from this raw data we are doing something like processing and analysis, and we are getting information from that. So what is information? So it is processed and structured data. So it is unprocessed unstructured data we are converting into processed and structured data. And this information is the product of initial analysis, and it will answer who, what, where and when. Say for example, we can get information like, so in the same previous example, we have collected the data from all the districts in Telangana, no? So in that here after processing and analysis, say for example, we got total fertility rate of Telangana is 1.9. So we are just knowing that the TFR of Telangana is 1.9. Here we are not interpreting or we are not doing anything. That means this TFR is low or high or it is normal. Should we do anything to improve or to decrease? So here not we are not analyzing it according to the context. So just we are getting after analysis TFR of Telangana is 2.9. So that is information. So this is nothing but processed and structured data after initial analysis. And this information we have to interpret according to the context we are talking about. So this intelligence will give actionable insights for decision making. Say for example, here TFR of 1.9. So we will see here we have interpreted that it is below replacement level. So replacement level of TFR is 2.1. So minimum 2.1 should be there to have replaceable TFR. But here it is not 2.1, here it is not even 2.0. So here it is 1.9 TFR. That means it is low. So to improve it, what can we do? So how can we improve, and how is the TFR in different districts, and what can we do? So like this we will see in intelligence. So we will make actionable insights for decision making, and this insights will be given based on experiences and perceptions, and it will consider social and political context, and it is predictive and strategic. Say for example, to improve the TFR of Telangana, recently in newspaper it came that the persons who are having more than two children, so they will be given some percentage of reservation to participate in politics, or to improve TFR to at least a replacement level or more than replacement level. What they thought is giving incentives for having third child, fourth child, like that. So what can we do based on the information we can see in intelligence? So first, raw data will be there, we should process and we should do basic analysis, and then we will get information, and this interpretation, when we are interpreting according to the context and according to the experience and perceptions, and we are using it for planning health services, then we will call it as intelligence. So you should know all these terms. And now we will see what are the requirements of health information system. That means to establish a health information system, what are the prerequisites? Say for example, we want to collect data regarding TB patients in Telangana. So how should we collect the data? So the data should be population based. So that means we should go to each and every village and districts, and from the district state. So from people we should collect the data. So not like whatever it is coming in the newspapers, or whatever it is coming in the news channels, or whatever it is there in the record. So not from that. The data which we are collecting should be population based, and we should avoid unnecessary agglomeration of data. That means, say here we are talking about only TB patients, so here we should collect only data regarding so the current TB patients. So unnecessary data should not be collected, and it should be problem oriented, and it should employ functional and operational terms. So here in this example, so what is presumptive TB case, what is microbiologically confirmed TB case, and what is clinically confirmed TB, what is drug sensitive TB, drug resistant TB. So priorly only we should have operational terms, and if they are following those terms, then we should use those terms, operational terms. And we should express information briefly. We should not go on writing essays kind of thing, and we should express it briefly, and we should have provision for feedback to have any improvements. And now we will see what are the components of health information system. Components means what we will collect in health information. So what we will collect, first thing is demography and vital events. Demography means, as you know, demos means people, graphy means study. So about population, that means their age distribution, sex distribution, so and all in details about people. And vital events. Vital events means births, deaths, marriages, adoptions, separations. So about vital events. And we should even collect the data regarding environmental health statistics. Environmental health statistics means water pollution, air pollution, soil pollution, say for example air quality index. So like that we should collect. And third thing is health status. What is the health status of the community? That means what are the mortality rates, like crude death rate, morbidity rates, for different diseases like communicable and non-communicable diseases, and what are the disability rates, and what is quality of life, and what is life expectancy. So all this we should collect. And remaining means health resources. Say for example, how many hospitals are there in Telangana, government hospitals attached to medical colleges, and how many bedded hospital is this, and what is the health manpower. Manpower means how many doctors are there, how many staff nurses are there, how many lab technicians are there. So like that, manpower, how many are there. So we should have information about health resources also. And what others will be there. So availability of health resources is not enough, utilization should be there. So that is nothing but utilization and non-utilization of health services. That means so attendance, admissions, waiting list. So admissions means, say for example, a hospital is 100 bedded hospital. So on an average per month, what is the bed occupancy rate? Bed occupancy rate means among those 100 beds, at least 80 beds are being occupied, 90 beds are being occupied. That means the utilization is good. So what is the bed occupancy rate we can see. And what is the OP? So per day, how many OP are coming to this particular hospital? So like that also we can see the utilization rates. And another thing is indices of outcome of medical care. Outcome of medical care means these patients are getting admitted or coming to the hospital. Are they being cured, or are they so they are being dead? So what is the outcome of the medical care? So that also we should know. And next. financial statistics. That means what is the cost of this medical care and what is the expenditure incurred to give this health services. So that also we should know. So all these are components of the information system. And now we will criteria we will follow while we are collecting this health related information or data. So the data whatever we are collecting should be relevant. That means it should be proper and it should be sensitive. Sensitive means sensitive to change. When so whether it if that for example crude death rate is increased and in the data whatever we are collecting, so it should show that this crude death rate is increased, so that is sensitive. And next is valid, and the data which we are collecting should be specific to that problem what we are collecting, and it should be sufficiently accurate. That means it should be near to correct data, and it should be capable for proper analysis and interpretation, and it should be complete. The data should be collected timely. So if we want to give the rates for 2025 year and if we are collecting the data of last year, what is the use? So it should be timely. So these are the criteria it should be followed while collection of the health related data. So till now we have seen introduction about this health information, and now we will see what are the sources of health information. So there are many sources of health information like census, registration of vital events, sample registration system, notification of diseases, hospital records, disease registers, record linkage, epidemiological surveillance, other health service records, environmental health data, health manpower statistics, population surveys, other routine statistics related to health, non-quantifiable information. So like this, there are 14 sources of health information. So this health sources of health information is important for short notes, very short, and sometimes it might come as long also. So first and foremost, we will discuss about first source of health information, that is census. So census is a Latin word and its meaning is to enumerate or count. That means here we are counting each and every citizen residing in India. And this census is an important source of demographic information, economic information and health information. See here we are collecting all this information, and this census is taken in most countries at regular intervals. That means not only in our country, this census is being done in most of the countries, and that too in regular intervals. Decennially means once in every 10 years. And in India, how frequently they are happening means this census started in 1881, and from then onwards, every 10 years it is being done. So 1881, 91, and 1901. So like that every 10 years, and last census happened in 2011. And after 2011, it should happen in 2021. Yes or no? Yes, but because of COVID, so we remember how much we suffered during COVID, and because of that, this census 2021 was postponed, and now it is being done in 2026 and 27. So now it is being done, census 2021. And when we will do this census means we will do at the end of first quarter of first year of each decade. Say for example each decade means in 2020s, 20s first year is what? 2021. So in the 2021 also, when we will do means end of first quarter of first year. So first quarter means 12 months will be there. So by 4, so 3 means so by the end of March. So by the end of March or April, we will do this census. So that is nothing but Jan to April 2021. We should do this census. So which is being postponed till now. And what is the legal basis for this census is Census Act of 1948. So according to this act, so the persons who are coming for enumeration, they have the right to enter into the house for this collecting the census details. And who will be the leader for this census means Census Commissioner of India. So Census Commissioner of India is the supreme officer who will direct, guide and operates this census. And this census primary function is demographic information. So although primary function is demographic information, that means how many people are there and what is their age distribution, gender distribution and all. But not only this census will collect a mine of information which is not only limited to demographic data. That means it will collect so much of information which will we will discuss in the next slide. So we have said that mine of information will be collected. What is that mine of information? First is demographic details as we discussed, and what is the socio-economic status? Socio-economic status of the populations, and what is their literacy level, and what is their education, and what is their housing and household amenities they are having. That means in one house what vehicles they are having. For example, so two-wheeler, four-wheeler, three-wheeler, or they are having fridge, cooler. So all this information, household amenities also will be collected. And details regarding urbanization, details regarding fertility, morbidity, mortality. That means what diseases are there, what are the dying patterns, and details about the scheduled caste, scheduled tribes, and what is the language, religion, and migration. So all these information in detail will be collected in this census. And to collect all this information, so what sequential steps will be followed? So first, to do this much work, first we should prepare. So what to be collected, what forms to be taken, so all the preparatory work will be done. And after this preparation, good preparation, actual enumeration will start. Enumeration means collecting all this information. So after collecting all the information, data processing will be done, and evaluation of results, analysis of results. And so after they know the what are the results, and disseminating of the result. Disseminating means, so this census commissioner of India will announce what is the population of India, what is the age distribution, what is the gender distribution, fertility rate. So everything, so everything they will be disseminated to the people. And after that, after everything is over, systematic recording of census experience. What is the experience? What can be changed? What can be added? So this is nothing but feedback. So all this will be done in sequentially. And this census data will be collected in two phases. And in phase one, what activities will be done means house listing and national population register. So house listing means first they will enlist what are the houses are there in India, and who are residing in that houses, and what are the basic amenities of that house, and preliminary data like what is the type of house, for example. So preliminary details will be collected, and they will schedule when to establish national population register. So national population register means it will hold permanent record of people residing in India. So and if any changes are there, it will be updated in that national population register. And this is in phase 1. And in phase 2, what will be done? Actual enumeration, actual details collection will be done in phase 2. So population enumeration means, so here all the details we have discussed, like enumeration, demographic details, economic details, education, occupation. So all the details will be collected in this phase 2. And after some gap, revisional round or follow up will be conducted, and any additions like any births, deaths happened, and any migrations happened, so they will be updated in this follow up or revisional round. So it will be conducted in phase 1 and phase 2. And now we will see what Census Act 1948 will tell. What are the obligations of us as citizens, and what are the rights of enumerator, we will see. So according to this act, it is obligatory to answer census questions truthfully. That means we should say it truthfully, and we should give complete details whatever they are asking according to the law, because it is protected by law. And say for example, if we are having car and if we are telling only bike like that, so we should not do. So we should answer the questions truthfully. And what are the rights of enumerator according to the Census Act? So this will give the right to enumerator to enter into your house. That means they can come into the house and see. And we cannot say that just go out, you can't enter to our house, like that we can't tell, because it is protected by law, census act. And so they can write or paint or affix the numbers on the building. So they will write our house number, and so they will see that it is enumerated. They will make sure that it is enumerated. They will paint or affix numbers, and that also we can't delay. And we should and they have right to ask all the questions which are printed in the census schedule. So they will come with a pro forma, and whatever the questions are there in that pro forma, they will ask us, and we should tell truthfully, and they will write in that papers. And they have the right to obtain all the answers from the respondents. So these are the obligations of us as a citizen, and these are the rights of enumerators to collect the data in census. Now we will see what are the salient features of last census, which is 2011 census. And the total for the census to be conducted was 22,000 million rupees, and per person they have invested 18.19 rupees per person. And what were the unique features means, so this much so much money and work, manpower, so it is not only possible with government, so they have utilized the support of non-governmental agencies also for training effort. And they have conducted census for schools also. And at that time 2011, they have introduced a new mascot approach. Mascot approach means lady enumerator. So they have utilized the photo of lady enumerator to represent 2011 census. And even they have utilized social networking like Facebook, Twitter also, canvassing purpose, and intelligent character recognition software. So at that time, whatever the software available, they have utilized that software also. And they have created national population register, NPR. So national population register means, so here permanently each and every person who are there in census, so they will be entered into that national population register, and they will be tracked. So whatever the changes are there, so all people will be included in national population register who are residing in India. Only, and not only that, as a mascot approach, Vikas, who is male enumerator, who is holding the tab, and Pragati is a female enumerator. She is also holding the tab or smartphone and coming for enumeration. So this much has to be done in census. So here, while doing all this, there are many challenges which will be encountered. Like sometimes there will be incomplete coverage. Like when the enumerator comes, the house will be locked and all. And so if unavailability of compilation procedures, and even failure to report all occurring events like death. Say for example, a person has died 1 month ago, but there is no one to report that. So that is failure to report. And data analysis like human resources, equipment, and time. So mostly this is they are trying to decrease all this by making it digital. And even under reporting and missed enumeration, so they are the challenges. And some more challenges like so here in India the population is scattered, some in villages and tribes and in hilly areas, so it is difficult to reach areas are also there. And illiteracy is there. Some, if they are asking details, for example, a old woman is there in the house which who is giving all the details about that house. Some she knows details will be given by her, but some details she don't know, how can she give? So because of illiteracy also, and lack of proper appreciation and awareness about census, and lack of proper communication. Say for example, they are collecting in tabs and all, so if they go to difficult to reach hilly areas because of lack of signal also, and long distances has to be traveled in difficult terrains like hilly areas, so like that. And so proper training should be given, and proper supervision to be done uh, for the enumerators to collect the data efficiently. So these are the challenges encountered. So census is completed. So which will be done every 10 years, once in a decade. So now we will see what is registration of vital events. So once in 10 years, if we are enumerating, means in this 10 years so many births will happen, deaths will happen, marriages will happen. So to keep continuous check on this vital events, so there is one more source of health information such as registration of vital events. So this will keep continuous check on demographic changes happening, and this is great importance in all countries. Why means, if this registration of vital events is complete and accurate, it will give a reliable source of health information, and it will be a precursor for all health statistics. That means to calculate any data have a denominator, so this will be useful. And this registration of vital events dominates the health information system if it is complete and accurate. And what legal basis it is having means, previously we had Births, Deaths and Marriages Registration Act 1873, but at that time it was voluntary registration of vital events. That means in your son is being born or dying, any marriages, separations, you can register voluntarily. It is not compulsory. And at that time Tamil Nadu, Karnataka, Assam are having their own acts. So but for India, so this was the act. So it was very unreliable. Why means, to register also they should have awareness first of all. So because of illiteracy, ignorance, lack of concern and motivation to report these events, and lack of uniformity in collection, means some states are having their own acts and India is having this act. And there is lack of transmission of data, and there are multiple places where this has to be registered, like health department, panchayati raj department, police department, revenue department, like that. So there are so many problems, and to tackle all these problems, a new act came, which will be discussed in the next slide. So the previous act was voluntary registration and it was not uniform in all the states. But the Central Births and Deaths Registration Act 1969 makes it compulsory to register births and deaths which are happening in the house. And whose responsibility is it to register means, if any birth or death or marriage or anything is happening in home, so parents, relatives, neighbors can register. And if it is happening in the hospitals, then heads of the hospitals, heads of the nursing homes. If it is happening in these hotels, heads of the hotels. If it is happening in jails, heads of the jails and heads of the dharmashalas has to report all these vital events. And states will compile all these vital statistics. And what is the standard time limit for registration means, in India, so it is 20, within 21 days of any birth or death we should do registration of that event. If we are not doing within that 21 days, we have to pay late fee and then we can register. So now the vital events like births and deaths topic came. So, and now we will discuss what death certificate or cause of death reporting will look like. So this death certificate will have two parts, part 1 and part 2. So in part 1, what are the sequence of causes are there for this death will be written, and in part 2, contributing conditions will be mentioned. So sequence of causes in part 1 means, first we will write what is the immediate cause. So that is, what is the disease or condition which led to the death. Say for example, pulmonary embolism. And in the second thing, why this pulmonary embolism came. That means due to or as a consequence of pelvic vein thrombosis. So this will write in the second step. So this pelvic vein thrombosis, this thrombus traveled to lungs and caused pulmonary embolism. And why this pelvic vein thrombosis came, due to or as a consequence of septic abortion. So because of septic abortion, pelvic vein thrombosis, and because of pelvic vein thrombosis, pulmonary embolism. But pulmonary embolism will be the immediate disease or condition which led to death. So this sequence of causes will be written in part 1. Here we will start with condition and we will work backwards. And in part 2, what are the contributing conditions, like other significant medical conditions or surgical conditions contributing to death but not directly related to the disease causing it. Say for example, that person is having diabetes mellitus or hypertension, so that we will mention in the part 2. And in this registration of vital events, we will see one term, that is lay reporting. Lay reporting is nothing but collection of information and its use and transmission to other levels of health system by non-professional health workers. So lay persons means here not uneducated persons or illiterate persons. Here lay persons means non-professional health workers. Say for example, village health guides, ASHA worker, Anganwadi worker. So these bottom level healthcare workers are collecting the information and they are transmitting this health related information to higher levels. So that is lay reporting. Why this lay reporting came means because there was so slow progression of development of comprehensive vital registration system, and that's why first line healthcare workers like village health guides will record births and deaths and they will transmit to higher authorities. And what information they will collect means, so they will conduct demographic surveys for vital events registration, but they cannot ensure complete record. That means this information from lay reporting is uh, just a substitute for the information which we are already having through census, registration of vital events or all other health information. To substitute that health information, this lay reporting will also add. And now we will see what is sample registration system, SRS. This sample registration system was initiated in mid 1960s, and this SRS will give reliable estimates of births and death rates. And so it is not only conducted in state level, so throughout India this data related to this births and deaths will be collected as a part of this sample registration system, and we will call SRS as dual record system because this continuous enumeration about this vital events will be done by the enumerator, which will go to field, and this enumerator will collect details regarding this births and deaths and other vital events. So this is continuous enumeration. So after that, independent survey will be conducted every 6 months by investigating supervisor. Investigator supervisor will go into field every 6 months and he will check whether the details given by the enumerator is correct or not. So whether these two are matching or not. So what the investigator supervisor got, how many births happened and how much enumerator will give. So if both coincide, then they will finally write as this many births happen, like that. So first continuous enumeration by the enumerator and second independent by the investigator supervisor. So that's why we will call it as dual record system. And there in web we can get SRS bulletin. So here in SRS bulletin we can get the latest details about birth rates, death rate, total fertility rates and all, which will be given for throughout India. So the salient features of SRS is enumerator is continuously checking and investigating supervisor is checking half yearly or once in 6 months, and it is having national scope as it is covering entire country, and it is giving reliable vital statistics about births, death rate, age specific mortality rate, infant mortality rate, under 5 mortality and adult mortality rates. And now we will see another source of health information, which is notification of diseases. So notification means here if we are seeing any case, we are notifying it to higher health authorities. And this notification of diseases is first health information subsystem. So that means it serves as a primary line of defense in health monitoring, and it will connect even local clinics. So this data will be directly sent to central government or higher government health databases. So this is first health information subsystem. And what is its primary purpose? To effect prevention and to control disease. Say for example, even recently also, yesterday, day before yesterday also, some COVID cases, new COVID cases has been reported from Andhra Pradesh. How we know? Because COVID is a notifiable disease. So whenever and wherever they are getting COVID cases, they are notifying it to higher authorities, state authorities and national authorities. So that's why we know that new COVID cases are coming. And what is the purpose of notification? So a person, for example, is diagnosed with COVID in AP. So we know that again this COVID is spreading, and what preventive measures we can again follow, like proper hand washing, wearing mask, social distancing. So like preventive measures, and what control measures we can follow to stop transmission from person to person and to decrease the burden. So what can we do? So that is the primary purpose of notification of disease. And because of this, we can also know incidence and distribution of notifiable disease. Incidence means how many new cases are coming, say for example, and distribution means where they are being located, these cases. And what diseases we should notify means, so it will differ geographically, and in the next slides we will see what are the notifiable diseases in India. And what is the legal basis for this notification means, Madras Public Health Act 1930 and Epidemic Diseases Act 1897 will form legal basis for notification of diseases. And we will see what is the reporting structure of this notification of diseases. So this notification of diseases is linked up with vital statistics machinery. And who will report means, if it is happening within the village chowkidar or headman, and previously especially, and now even village health guides, multi-purpose workers, ASHA workers. So in the place where the test have been conducted, say for example primary health center, then community health center, so whatever is the health center, so they will notify to higher authorities. And international health regulations, that means some diseases, so if it is happening within our country, we should report to WHO, World Health Organization. So cholera, plague and yellow fever are the diseases. According to international health regulations, if we are having any cases of these diseases, we should report to World Health Organization. And some diseases are in international surveillance list. That means this WHO is collecting information about what is the caseload in all countries about these diseases. So that is international surveillance list about louse-borne typhus, relapsing fever, polio, influenza, malaria, rabies, salmonellosis. So they are in international survey, even COVID also. And how about one country, other countries will know health information means, so this World Health Organization will collect this health related data about all these diseases from all the countries, and it will publish the information. So like that we will also know in what countries what diseases are there. We will think that only communicable diseases are notifiable, but it is not like that. Even non-communicable diseases are also notifiable. So we will see what diseases are notifiable diseases in India. So vector-borne diseases like dengue, malaria, Japanese encephalitis, and even food and water-borne diseases like cholera, typhoid, hepatitis C, and even vaccine-preventable diseases like measles, polio, and infections like tuberculosis, rabies, and even recently last year I think snake bite is also added to the notifiable diseases. And what are the objectives of this notification? Because we will have yearly data about those diseases. Say for example, snake bites. So what is the age pattern of the snake bites? What is the gender pattern of the snake bites? Last year, how many cases happened in each state and throughout India? And we can monitor fluctuations. That means whether they are increasing or decreasing. So if it is increasing, we can give early warnings about new occurrence of outbreaks. And even we can track these diseases. As we discussed, even congenital malformations will be there, mental illnesses, stroke, handicapped person, so these are also notifiable diseases. So we can track these diseases by notification. But this notification of diseases also are having limitations, because they will cover only small part of total sickness in the community. That means the diseases which are notified we know, but if some persons are suffering with the disease, they are not tested, we will not know about that. And even tested also some people will not notify, so them also we will miss. So we will cover only small part of total sickness in the community because of under reporting or because of non recognition of disease. Say for example, in rubella or non paralytic polio, subclinical forms will be there. So subclinical forms means it is not even diagnosed, so we cannot notify. So this is the limitation. And now we will see what is the other source of health information. So it is hospital records. So this hospital records means, say for example, OP sheet or discharge sheet you think as example. So this hospital records will give basic and primary source of information about diseases prevalent in community. That means for what diseases they are coming to hospital. So prevalent diseases in the community we can know. And because of this data in hospital records, um, it should be an integral and basic part in national statistical program. And this hospital records will give useful information about healthcare activities and utilization. That means, say for example, CHC is there and it is giving specialized healthcare services. And so for all the health problems, are they coming and utilization is there or not, with bed occupancy rates and all we can know with hospital records, how many beds occupied and all. And what informations will be there means, as we discussed, discharge sheets will give information about what is the diagnosis and what are the medical treatment given, what are the surgical procedures done, and what are the complications of that health problem, what is the duration of stay in hospital, and what are the lab tests done, and what are their reports. So all these details will be available in hospital records. And not only that, we can know the geographic location of that deceased person. So in admission sheet their place is also written, so with that we can know the geographic location. And not only that, their age distribution, sex distribution according to diseases, and duration of hospital stay we can know. And we can even know distribution of diagnosis. That means we are taking for example MGM hospital, which is located in Varangal. So in Varangal, what cases are majorly there? Say for example, communicable diseases, non-communicable diseases, and in that also hypertension cases are coming more, diabetes cases are coming more, or communicable cases diseases are coming more. So distribution of diagnosis we can know with this hospital records. And not only this, association between different diseases. Say for example, tuberculosis HIV, tuberculosis diabetes. So with after analysis of all these hospital records only, we came to know that association is there. So now we are integrally checking all the TB patients with HIV and diabetes. So association between different diseases also we can know. And the period between disease and hospital admission, that means after having clinical feature, after how many days the person is coming to hospital and getting admitted, so that also we can know. And we can even know the distribution of patients according to the social status, biological characteristics, and even we can know what is the cost of hospital care for each disease. And now we will see what are the advantages and disadvantages of hospital records. Advantages means, as we have seen, it can have a great value in planning of healthcare services. Say for example, rabies cases are more coming to this particular hospital, and so in that hospital we will make sure that every time this immunoglobulin should be available, anti-rabies vaccine should be available, like that. For planning and implementation of the healthcare services will be there if we have data from hospital records. And as we have seen, we can know the bed occupancy rates, duration of stay in hospital, cost effectiveness of the treatment policies, monitoring and use of hospital facilities. We can it will be useful. And even hospital statistics will be maintained by medical record department. So in hospital, medical record section will be there. So in that medical record, about all the patients details will be there, about admitted patients, OP patients, what is the diagnosis, surgery, treatment, about all details will be there. And even we can digitalize that data from medical records into the system. But what are the disadvantages? So the patients who are coming to hospital will represent only tip of icebergs. That means the people who are having only clinical features, that too somewhat moderate to severe only, will come to hospital. Say for example, mild illness may not come to hospital, and if it is subclinical form, they will obviously they will not know and they will not come to hospital. So this is one disadvantage, and admission policy will be different in different hospitals. In some hospital, moderate cases also they will admit. In some hospitals only, somewhat severe cases only they will admit. Like that, admission policy will differ from hospital to hospital, and population served will be ill-defined. To calculate any rates, we should know what is the mid-year population of that particular community. But the population served will be ill-defined. Say for example, a good hospital there in Varangal. But to that hospital, only from Varangal people will come? No. From other districts also will come. If they think that this doctor is seeing well. So the population, the denominator will be ill-defined because the population will come from different places. So these are the advantages and disadvantages of hospital records. And now we will see other source of health information like disease registers. What is disease register? So it is not notification. So disease register goes far beyond simple notification. Notification means what we will do. So from this particular place, this particular age person, particular gender has diagnosed with this disease and he is from this location. So only basic details will be given in simple notification. But disease register means it will establish permanent record of, for each case. And permanent record means the details of each case will be permanently documented and they will be followed up over a time depending upon the disease. Say for example, for tuberculosis, disease registers will be maintained. So from that diagnosis onwards, what treatment they are taking, are they coming for again microbiological testing or not, they will come for monthly follow-ups and for taking treatment or not, so they will be cured or not, or they are becoming resistant cases or not. So everything will be documented in this disease register. So they will give in detail data. And not only that, research foundation means patients in this particular disease registers will become subjects for special studies and research. That means, say for example, if we want to do study in tuberculosis patients, if we want to see survival rates and conversion into drug resistant cases, if we want to do some study, so from where we will think, from where we will get this cases. So we can think that so disease registers are there, so from these we will take sample and we will do the study. Like that, research will be conducted among these population, and this registers will provide frequency data on diseases and it will track survival rate. That means among the patients who got enrolled into this disease registers, are they being cured, are they being like stopping the treatment, or what are the survival rates of those patients also we can track. And for what diseases this disease registers will be there means, for tuberculosis, leprosy, stroke, myocardial infarction, cancer, blindness, congenital defects, congenital rubella. So like this, for these diseases, disease registers will be there and they will be tracked. What are the benefits of disease registers? It will provide useful information on, so as we are following up them, especially chronic diseases we are following up. So in between we are doing follow-up visits. So like with help of that we can know the national course of chronic diseases or national history of chronic diseases. And if people think that notification means if we notify, our name will be written like that. But if we are enrolling into register means they will give treatment, they will track like that. If they think, notification will improve with help of disease registers, and it will ensure good coverage, and it will give useful data on morbidity patterns, treatment, mortality of those patients. And now we will see what is record linkage. Record linkage means a linkage of different records particular to one individual or family, which are happening in different times and places. So linking records together. But here in health sector, what is treated? Medical record linkage. That means assembly and maintenance of file for each individual like relating to its health. Say for example, one person got fever and went to hospital and got admitted and cured and came out, and after 1 year again he got some health problem and went to hospital. So bringing all this health information together relating to one individual or family is nothing but record linkage. And for what we will follow generally record linkage means about births, marriages, deaths, hospital admissions, discharges, and sickness absenteeism from works, and any prophylactic procedures are being done, and use of social services. So for this generally record linkage will be done. And what is its application and significance? So in one person only different diseases, so like that. So we can study association between different diseases. So like this we can know the etiological significance of those diseases. But in practice, so that is theoretical, but in practice, this record linkage is being done for only specific health problems, like it is being done in twin studies, measurement of morbidity, chronic diseases, and family and genetic studies, like that. Why we can't do for all individuals and all diseases means the volume of the data is so much, and to maintain that volume of data and store, we need manpower and money. So it is beyond reach for many developing countries like India, and it is only being followed in developed countries like England, Canada, and Scotland. And now we will see about other source, that is epidemiological surveillance. So we know what is surveillance. It is continuous collection, analysis, interpretation, and feedback of systemically collected data. That means we are continuously watching over that particular disease. And that means we are seeing any new cases has come. So any complications are there, what is the death patterns to that particular diseases. So we will keep surveillance for some diseases. For example, malaria, to report the occurrence of new cases and on efforts to control the disease. Say for example, immunization is being conducted properly or not. What about the vaccine preventable diseases? Are they increasing, decreasing? So like that, surveillance will be conducted, and this surveillance will yield morbidity and mortality data. And there are two different types of surveillance. One is active surveillance and other is passive surveillance. And one more surveillance is sentinel surveillance. So this is important for very short also. Sentinel surveillance means surveillance for missed cases. So the surveillance which we will do for missed cases is sentinel surveillance. For example, vaccine preventable diseases in children. And we have seen surveillances of two types. One is active surveillance and one more is passive surveillance. Active surveillance means we will do active efforts to find the cases. So this is nothing but active case finding. This we will follow in malaria, active case finding. So active case finding means health worker only will go to community and they will search for malaria cases. Say for example, that means that Asha worker will go to community and she will identify all the cases who are having fever, and those fever cases will be tested for malaria. So to find malaria cases actively, that means health worker is only going to community and searching for the cases. That is active surveillance. This is expensive because we are conducting tests for all the suspected cases, and health worker itself is going to community. This is expensive. And examples like malaria eradication program, Viniyavam eradication program. And passive surveillance means the person who are having signs and symptoms will come to doctor. So and this doctor, medical officer, will check patients for symptoms of disease under surveillance. Say for example, disease surveillance is going on for say for example tuberculosis. So the persons all who are coming to hospital with the symptoms like of more than 2 weeks, weight loss is there, night sweats is there, so they will be advised for sputum testing for tuberculosis. So the patients itself are coming to a doctor or hospital with signs and symptoms. So that is passive surveillance. And this medical officer or doctor performs relevant examination and submit the periodic reports. And this is the most common form of passive surveillance. as active surveillance is expensive and needs more manpower and resources. So we will follow passive surveillance more. And now we will see about other health service records. So records like hospital outpatient departments and health records from primary health centers, health records for sub centers, polyclinics, health records from mother and child health centers, school health records. So for particular aspects, particular records will be available. And what data we will get from those uh, health record means, say for example, MCH hospital is there, and those MCH records will tell details about birth weights of the babies who got delivered there, and their height, arm circumference, their immunization status, their disease specific mortality, morbidity will details we will get from those health service records. And what is its primary use means, it is used for administration purposes, that means planning and implementation of the health services. And the drawback means only segment of the general population is covered based on from where we are collecting the data. And now we will see about environmental health data. Why environmental health data is needed means, we are in close contact with our environment, which is air, water, soil and all. And because of pollution of those environment, we are getting diseases. So that's why this is data is needed. And by the now information related to environmental health data is still lacking. And so environmental health data will include data on air, water and noise pollution, and not only this, so about harmful food additives in the foods we are consuming, industrial toxicant, inadequate waste disposal, increased production and use of goods. So all this information is should be tracked. And we should identify and quantify causative factors. For example, air pollution is there. So, what are the factors increasing air pollution? So, usage of old, damaged vehicles, or use of leaded petrol. So, what are the factors which are leading to this? And we should quantify those factors, and we should look for a way to decrease this pollution. And National Institute for Research in Environmental Health, Bhopal, is monitoring all this. And now we will see health manpower statistics as a source of health information. Health manpower statistics means how many healthcare workers are there for general population. This statistics is known as health manpower statistics. Say for example, how many doctors are there for population, how many dentists are there, pharmacists are there, hospital nurses are there, and what is their residence place, like that. So this data is health manpower data. And there is WHO recommended data for doctors that at least one doctor should be there for 1,000 people. Did we achieve this? Yes, now in India, one doctor is there for 811 population. So for 811 people, one doctor is there. So already we have crossed this, and still this medical seats are increasing. So that is different, and but uneven distribution is there. That is for sure. And who will give this health manpower data means, so state medical council, state dental council, nursing council, and even DME, Directorate of Medical Education, will have this data related to health manpower. And even census, during census also they are collecting details about their occupation, so there also we can get health manpower statistics. And even medical education wings will have number of admitted medical students and number of qualified medical students every year, so that also we will have. And so this data will be maintained throughout India in Institute of Applied Manpower Research, and this is renamed in 2014 as National Institute of Labor Economics Research and Development. And even Planning Commission estimates active doctors for different states. And now we will see about population surveys as a source of health information. So population surveys means here we will do population based surveys or research. This is nothing but research we will do. And why we should do population surveys means already existing sources of health information or data is not providing needed information. So when they are not providing all the health information, health and disease in the community, so we can plan new research or study and we can conduct. And what is the survey scope? This population surveys will supplement the already existing data. On what we can do means health surveys can be conducted relating to any aspect of health. So like on whatever the diseases we can do studies or research like cholera, malaria, plague, respiratory disease, fevers, diarrhea. So whatever it may be, we can do research. So in whatever the area we are interested in, we can do the studies. Even as a part of post graduation thesis and publications, so many doctors are doing this surveys or studies or research. And what is the survey design and setting means we can do any setting which is nearby or far also depending upon our interest. And we should follow appropriate sampling techniques like simple random sampling, systemic random sampling, stratified, like that. We should follow appropriate sampling techniques to estimate the level of precision with available resources. And what type of study we should do means depending upon the research question, we can do cross-sectional studies or longitudinal studies, and even descriptive studies we can do, analytical studies we can do, both we can do, and even randomized controls, clinical trials also we can do. Whatever are the study design ethically if we are conducting, we can do. We can do population surveys for various reasons, like we can conduct a research or surveys for evaluating the health status of the population. Say for example, their health status is good or not, what are the morbidity profiles, like what are the prevalent diseases, and even what is the incidence of that particular disease, and even what is the distribution of those diseases, and for planning and developing the health services for that particular diseases, we can conduct research or study. And also we can conduct a survey for investigations of factors affecting the health and disease. Say for example, if it is non-communicable diseases, risk factors or factors affecting the health and disease, even we can that we can investigate. To know the natural history of the disease and to know the etiological factors and to know the risk factors, we can conduct surveys. And we can conduct surveys relating to administration of health services. Say for example, what are the uses, how many people are utilizing the health services, and what are the health expenditure patterns, and what are the health needs of the population, and what are the unmet needs of the population. That means they are needing those health services, but we are not providing those health services, so that are unmet needs. And even evaluation of medical care. So we can do for all these three purposes, we can conduct surveys. One is evaluating the health status, second one is to investigate the factor affecting the health and disease, and third is relating to administration of health services. Whatever is the purpose of health surveys or population surveys, we can conduct in different ways. First one is health interview survey. That means here we are doing the interview of the patient or person face to face. And second is health examination survey. That means we ourselves are doing health examination and collecting the data. And health record survey. That means we are not directly approaching the patient or that person. We are collecting data from medical records or registers. And mail or questionnaire survey means we are mailing them the questionnaire. So they are only reading those questions and answering to that questionnaire. Each method is having its own distinct set of advantages and disadvantages. And what type of survey we want to do, we ourselves must carefully choose when planning the study, depending upon the details what we want to collect. So now we will see about each health survey in detail. So first is health interview survey. So as we have discussed here, the investigator and the study participant or patient will sit face to face. And when the investigator is asking questions, this participant will answer the questions related to health. And this method will measure the subjective phenomenon. That means how the patient or the person is feeling and what they know they will answer. And it is in this we can collect data regarding morbidity, disability, impairment, economic loss, opinions, beliefs, attitudes. So and all about this we can collect data. What is the advantage means it is giving population based data, not like record based. But morbidity data is not reliable. That means about the disease or health problem, what they know they are telling. We are not doing any health examination here to collect the uh, remaining data. So this is about health interview survey. And health examination survey means here team of doctors, technicians interview together will do health examination of that patient, and they will collect data. Say for example, health examination means anthropometry we can do, height, weight, mid upper arm circumference to know the nutritional status in under 5 children, or vitamin A deficiency, bite out spots. So here health examination we will do and collect the data. So here experts or healthcare workers itself are doing health examination. So here the morbidity data will be more valid. But so like this for even lab tests also will be done if needed depending upon the disease we are studying about. But this survey is expensive and we can conduct only on small scale because it needs more manpower and money. Uh, and uh, uh, and to get the better results, we can combine this health interview survey along with health examination survey. And now we will see about other population surveys like health record survey and self-administered questionnaire. So first health record survey. As we have discussed here, health related information will be collected from health records. Say for example from hospitals. For example, if we want to do study about tuberculosis, we can collect records from district tuberculosis office and we can do study. This is the cheapest method because no need to travel anywhere. So by sitting in one place, we will get all the related information. But disadvantages are there like this estimates what we are obtaining are from records, not from population based. So if it is entered correctly, then only we can get correct results. But if it is not entered correctly, then reliability of the data is open to question. And even lack of uniformity in procedures and standardization in recording the data. Say for example, if we want to conduct research about surgery in appendicitis, so some in some hospitals, so this particular diabetes diameter of this appendix surgery will be done. But in other hospitals, if the diameter is more, then only surgery will be done. So like that lack of, and someone will some hospitals will do open surgeries and some hospitals will do lap surgeries. So lack of uniformity in procedures. So that is also one disadvantage is health record survey. And last is type of survey self-administered questionnaire or mailed questionnaire. So here we are not directly collecting details, health related details from the study subject. Here we are mailing the questionnaire, and there the participant is sitting in their home and they are answering to our questionnaires. And it is also subjective phenomenon what the participant is thinking, and what she knows, what that person knows, they will answer. And here no interviewer is there, they are only reading the question and they are only answering the question. So the advantage is like it is simple and cheap. So investigator need not to go anywhere, and they will get the data. But certain level of education and skill is expected in the respondents. Then only they will understand the question and answer properly. But high rate of non-response. Say for example, we are sending the questionnaire, mailed questionnaire to 100 members. So all those 100 members may not respond. Only 50 will respond. Only 60 will respond. So non-response rate is high in this self-administered questionnaire. So these are the different types of health surveys or population surveys. After population surveys, we will see other routine statistics related to health. So we have demographic, economic, and social security schemes. So demographic means we will collect demographic details. In addition to census, we will also collect demographic details such as population density, population movements like migration, and their education level details will be collected. And economic details like their per capita income, their employment status, unemployment rate in each states and districts, and even consumption of tobacco, dietary fats, and drugs and remedies. So all these details also will be collected intermittently. And social security schemes like what is the illness pattern in insured population, healthcare schemes being utilized like Arogyashri, Ayushman Bharat, employee health insurance, EHS, so like this, and sickness absenteeism, sickness and disability benefit rates. So all these details will be collected as a part of other routine statistics. Some health information we can quantify. Quantify means we can enumerate. Say for example, health manpower statistics, we can count how many doctors are there for population. But some health information will be there which is non-quantifiable, which we cannot measure. So, and who uses this non-quantifiable health information means health planners and decision makers. That means, does this community or population needs any health services? Any new health program is needed in this country. So, like that, health planners and decision makers will need this kind of information. And what is non-quantifiable health information means qualitative data. Qualitative data means information on health policies, health programs, health legislations. How is their public attitude towards these health services, and how are their attitude towards these health programs, and what are the program cost incurred. So this will come under non-quantifiable information. And so there are multidisciplinary inputs will be there. So from all these disciplines we will have inputs about this non-quantifiable information like social scientists, economists, community members, and contribution from various fields will be there. And we should have proper storage and dissemination of this non-quantifiable health information. So till now we have seen all the 14 sources of health information. So this health information systems will manage all this health related data. And this health information from past, from on paper onwards. So they used to collect the details, health related details and information on papers. So on from papers there was tremendous shift to computer based processing and storage. And so because of this computer based storage there are advantages like improved functionality. That means so if it is in papers we should store it properly, so we should keep it safe. And when there is a need to analyze we should go through all the papers to find one paper or file. But if it is computer based, so by entering into that system we can get the all the details about that particular patient. So improved functionality, better opportunities in using patient data or medical knowledge. But we need higher technologies to do all this currently. But we are having all these technologies. So this is the past and present and future of this health information systems. So thank you everyone for listening very patiently and coming to this slide. But you should know in detail about each and every health sources. That's why I explained it clearly. Thank you all.